Okay, so neuromuscular blockade monitoring, it's a very important topic in anesthesia. You have to know it. It's examined in the diploma exams, in the part 1 exams, and in the part 2 exams as well. So it's extremely important because if you do not understand this, it does put the patient's life at risk. Because what happens is you're going to extubate a patient that has got residual muscle relaxant on board, or you will attempt to try and intubate a patient who is not fully relaxed, and then that might lead to catastrophic outcomes. So that's why it's important to understand how this works. So the outline of the presentation is that we're going to look at the introduction, neuromuscular junction physiology, basics of muscle relaxation, the neuromuscular blockade monitoring, which is our main focus for today. We'll have a small discussion in the conclusion. So when we look at the typical triad of anesthesia, the triad involves amnesia, analgesia, and muscle relaxation. So I think you might have already have covered a little bit on amnesia and analgesia, but the focus on this presentation is the aspect of muscle relaxation. And in order to monitor these aspects of the triad, there are different modalities. So for analgesia, there are different modalities that are available to monitor how well analgesed the patient is, but they're not very sensitive. Hypnosis, I think we've gone quite far in terms of that. I think in the previous tutorials, we talked about, they might have talked about bispectral index monitoring, and BIS has also advanced in that now. We also have the DSA, which is the spectral array monitoring of patients' level of awareness, which shows the alpha and beta and delta bands. And entropy, I know we still have entropy as well, but there is a lot that can be said about monitoring for hypnosis. And that field is advancing. But when it comes to muscle relaxation, and not much has happened in terms of changes relating to neuromuscular blockade monitoring. Basically, the monitors are generally the same. There might be a few things here and there, but the principles over the years have remained the same. So in order to understand how neuromuscular blockade monitoring occurs, we have to start with the physiology. So at the level of the neuromuscular junction consists of the nerve fiber and the muscle fiber. And in between that, we have what we call the synaptic cleft. So what happens is that there's an electrical signal, which is your action potential, which is converted into a chemical signal in the form of acetylcholine. This is then converted to an electrical event that results in depolarization. The depolarization then leads to a muscle response, that is muscle contraction. This is what happens when a muscle contracts in your body. You get a signal coming from the brain. It might be voluntary, it might be involuntary. This is conducted as an action potential to that particular muscle. It's converted to a chemical signal in form of acetylcholine. The acetylcholine is conducted down the nerve fiber, and then the vesicles open up and release acetylcholine into the neuromuscular junction, the cleft in particular, synaptic cleft. The acetylcholine then migrates to the acetylcholine receptors, binds to the acetylcholine receptors. This then leads to the depolarization at the level of the muscle, then leads to muscle contraction. There's a video I'm going to show you. I have to declare that I did obtain this video from YouTube. It's not mine. However, I did modify it so that it may be relevant to the audience. Okay. So this is the video. It really helped me to understand the physiology of the neuromuscular junction, because I used to struggle to understand this, but it's quite simple. So what happens is you get that electrical signal, which is a form of electrical action potential. You've got calcium channels that are open. The calcium moves in to the nerve fiber. This then leads to the mobilization of these acetylcholine vesicles, which then move, they fuse, they release acetylcholine to the synaptic cleft. The acetylcholine then binds to the acetylcholine receptor at particular binding sites. This then leads to the efflux of sodium. So sodium moves out, and then you get, influx of sodium. So sodium moves in, and then you get an efflux of potassium. So potassium moves out. So imagine when we give succinylcholine, how it causes an increase in potassium is because of the efflux of potassium. This then leads to a depolarization. The depolarization leads to the muscle contraction. Then the acetylcholine is broken down by acetylcholinesterase into choline and acetic acid. Then there is this recycling process, and the process starts again. So this is the normal physiology that takes place when muscle contraction takes place at the neuromuscular junction. So this is the acetylcholine receptor that Dr. Folokwe is going to spend time with you going over it. At the level of the DA, you may not be required to know details on it, but what's important to know is that it's got 5 subunits, and then the subunits vary in neonates and in adults. But generally, you have an alpha, you have 2 alpha subunits, a gamma, a beta, and you've got, I think this is theta, if I'm not wrong. So basically, it's 5 subunits, and these there's a conformational change once the acetylcholine binds to this receptor. The receptor opens up, as you saw in the previous video, and then that leads to sodium moving inwards while potassium moves out. Same thing showing you again, the sodium ions and the potassium ions. So the sodium moves in while the potassium moves out. So what are the drugs that work at the level of the neuromuscular junction? So the main drugs that are available can be classified as depolarizing and non-depolarizing. So there are different types of depolarizing muscle relaxants, but the main one in clinical use is succinylcholine, which is otherwise known as Sux or Scoline. What it does is that it kind of exacerbates, if I could say that, the normal physiology, because how it works is that when it binds to the acetylcholine receptor, it causes sodium to move in, potassium to move out. But however, it leads to an hyperpolarized state of the membrane, which then leads to those fasciculations and the flaccid paralysis. So in a way, we could say it overdoes it. How does it overdo that process? It leads to an increased release of potassium, which then leads to hyperpolarization. So of the membrane. So you're getting all this potassium going out, and the action potential becomes minus. And that's how succinylcholine works. And that is why succinylcholine is contraindicated in the presence of hyperkalemia, because it potentiates the efflux of potassium, and that's how it causes muscle relaxation. It is broken down, succinylcholine is broken down by pseudocholinesterase. So its effects wear off as pseudocholinesterase breaks it down. And the effects of succinylcholine at about 1.5 milligrams per kg is up to 10 minutes. However, if you are giving an infusion, which we no longer do, or you give subsequent doses, you give like maybe 3 milligrams a kg, more than that, you are more likely to get what we call a phase 2 block, or in a patient who has succinylcholine apnea, the effect of suxamethonium is going to be prolonged, and hence the patient is going to be paralyzed, but for a longer period. But most patients don't have that abnormality. It can be acquired. Suxamethonium apnea can be acquired, or it can be genetic. There are conditions that put patients at a higher risk of having prolonged neuromuscular blockade after receiving suxamethonium. For example, if a patient has got liver disease, or a patient is pregnant, or a patient is cold, they are in a hypometabolic state, there is a chance that they can have prolonged neuromuscular blockade. Then you have your non-depolarizing muscle relaxants. There are many of them. The example I've put here is esmolol. The trade name is rocuronium. It works differently from suxamethonium in that it is a competitive nature. So it's antagonistic, and it's competitive. So it competes with the acetylcholine for the binding of the acetylcholine receptor. That's how it works. And how the patient recovers from non-depolarizing muscle relaxant is based on how well the body is able to clear it from the neuromuscular junction, and also the metabolism of this drug and its excretion as well. So drugs like rocuronium tend to have a prolonged neuromuscular blockade time, up to like 45 minutes at a dose of about 0.6 milligrams per kg. If you give 1 milligram per kg, which is the rapid sequence dose, you can even get a blockade of about 90 minutes. This is important to know, because when you are now using the monitoring devices, you need to know in your mind as to when did I give this muscle relaxant, and what is it I'm getting on my monitor. Is there a correlation or no correlation? So for example, if I've given suxamethonium and I'm using a nerve stimulator and I'm having fade, that is a concern, because typically suxamethonium does not give you a fade. So it would probably mean that the patient was given, can I say, or quote unquote, an overdose of suxamethonium. So you need to have that clinical aspect in mind, and not just use the monitors in isolation. So this is the structural formula of acetylcholine, which is acetylcholine and suxamethonium. So if you look here, suxamethonium or succinylcholine is actually two acetylcholine molecules bound by ester bonds. And what happens is that the succinylcholine is broken down by the pseudocholinesterase. Okay, so I've already spoken to you about that. So in general, why do we paralyze patients? The reasons are that you want optimal intubation conditions so that you don't struggle, and you reduce the patient's risk of in triggering the gag reflex and then vomiting, and also reducing the chance of the patient aspirating if you're trying to manipulate and the patient is not well relaxed. Also, we paralyze patients for adequate mechanical ventilation, both in theater and in the intensive care unit. Sometimes you need to ventilate the patient because you may be struggling to ventilate the patient, so you decide to paralyze them. For optimal surgical conditions, if, for example, abdominal surgery and the surgeon is operating and the patient is breathing, the bowel is being pushed down, and the surgeon will not be happy with that, because it just makes the surgery difficult, and it becomes difficult to identify structure. So you paralyze the patient for that. You may paralyze the patient sometimes also if you want to do imaging studies. Sometimes when there are certain MRI imaging may be required, and they might not want the patient to breathe or move. But generally, due to the advances that we have made at the moment, we used to paralyze patients for studies like MRI, but now we tend not to, because there's so many drugs that we have available. But occasionally, sometimes they might want you to paralyze the patient so that the radiologists and the radiographers get good images and reliable images. So sometimes that is required. So the pharmacokinetics between different patient groups is different, and you need to appreciate that from a clinical aspect. So I'll give you, for example, succinylcholine. So in an obese patient, the way you dose succinylcholine is dosed according to the patient's total body weight. So if this man's weight is 100 kgs and we said succinylcholine dose is 1.5 milligrams per kg, you would be giving him 150 and above. Because why is that you have to give a higher dose? Is because patients who are obese have more pseudocholinesterase. So before you actually attempt to intubate the patient, you might find that the succinylcholine has already worn off. And I've seen that happening where a junior is trying to intubate a patient, an obese patient. They gave a small dose of succinylcholine. They wait for it to work. But by the time they are instrumenting the airway, the patient is already beginning to cough. So succinylcholine, you dose it total body weight. Children, we try not to use succinylcholine because of the risk of malignant hyperthermia. Some of them have got myopathies. In pediatric population, you can also get bradycardias that can lead to cardiac arrest. So children, generally, succinylcholine, we don't use it. But you would use in a child, you would look at 1.5. If you needed it in an emergency like a laryngospasm, you needed to use it, then you would consider using it. And then here, the gentleman there, fit man, you probably could get away with 100 and you'll be able to intubate him. So I just want you to think about the fact that when you are using these muscle relaxants, you need to think about also the body habitus of the patient, especially when it comes to succinylcholine, which you use quite often in the obstetric population to intubate them. Okay, so coming to the focus of this presentation, because I've been giving you all this background, we're going to zero in on the subject today, neuromuscular blockade monitoring. So why monitor muscle relaxants? It's standard practice. So if you're not doing it in your theater, you're not adhering to the standard practice. And if you're not adhering to standard practice, to a certain extent, you are putting patients at risk. Why do we monitor? Adequacy of relaxation for intubation in surgical procedure, to guide subsequent drug administration. So this is important, especially if you are new, you're starting up in anesthesia. We remember those days where the patient coughs, but it's towards the end of the procedure, and then you end up giving a lot of rocuronium, and then the surgeon is done, everyone is done, and then they're waiting for you to wake up the patient, but you can't because you still have muscle relaxant on board, because you made a mistake and gave a high dose of muscle relaxant. So using a nerve stimulator will help you and guide you as to when you should give subsequent doses and how much you should actually give. It helps you to determine when to administer reversal agents, which is very important. It mitigates the risk of recuriorization. So recuriorization talks to the fact that if a patient, for example, you've reached the end of the procedure, you decide to reverse the patient, most of the time we're using neostigmine and drug like Rubino. If you give the muscle if you give the reversal agent like neostigmine and Rubino too early, what happens is, because it's an anticholinesterase inhibitor, you get an influx of acetylcholinesterase, which then leads to return of muscle contraction and muscle reflexes, and the patient actually breathes for a short period of time. But because the reversal agent only lasts for about 30 minutes, and you still have residual muscle relaxant on board, when the effects of neostigmine wear off, what's going to happen is the patient is going to be blocked again by the residual muscle relaxant, and the patient may not be able to breathe. You put the patient at the risk of aspiration and hypoxic arrest. We call that recuriorization, where you previously reversed the patient, but then they get blocked again by the muscle relaxant that's still circulating in the body. So that's why it's important to use a nerve stimulator to know when you should actually reverse a patient. So a train of fall of more than 90% is the gold standard for extubation, where there is no contraindication for extubation exists. And I had to add that statement because when you're extubating a patient, you have to also think to yourself, okay, train of fall might be more than 90, but if the patient is hemodynamically unstable, or the patient has got metabolic acidosis, then you can't extubate that patient. So you can't just take one thing in isolation. You have to consider the clinical picture of the patient. So before you just extubate, you have to put everything in context. What do we monitor exactly? So in order to understand the monitoring, you need to understand the main muscles that we focus on when we paralyze patients. So when we give rocuronium or succinylcholine, the muscles of interest are what we call central muscles and peripheral muscles. So the central muscles that are of interest are the muscles of the pharynx and the diaphragm. So once you get paralysis of the diaphragm, the patient stops breathing. And once the muscles of the pharynx are paralyzed, what then happens, you lose airway reflexes. This is advantageous if you're going to be intubating the patient, because you don't want the patient to gag, you don't want the patient to cough. So you want the diaphragm to be paralyzed, you want the pharyngeal muscles to be relaxed. However, I'll show you in the next slide the interesting thing, scientific interesting thing. And then the peripheral muscles themselves are also paralyzed when you give the muscle relaxant, but they tend to be what you call we tend to use them because it's much easier for us to measure the effects of the muscle relaxant using the peripheral muscles. And I will explain to you why. Okay. So the peripheral muscles are actually not involved in your intubation process, because what you're concerned about when you want to intubate, you want the patient relaxed. You don't want them to breathe. That's the central muscles. But to monitor, we use peripheral muscles. So I will explain why that is. So this is a chart that's showing you the depression of the response after a patient has received muscle relaxant. So we see that the diaphragm requires a higher dose of muscle relaxant than the adductor pollicis to be relaxed. This is good because it's a survival mechanism, because the body has been made such that the diaphragm is resistant to muscle relaxation. Why is that? So that you can breathe for as long as possible to keep you alive. So the diaphragm will require a higher dose of muscle relaxant in order for it to be relaxed. However, on the flip side, when the muscle relaxant actually begins to wear off, the diaphragm begins to move before the adductor pollicis begins to be able to be stimulated. And I think if you've done a lot of cases in theater, you would have noticed that during the surgery, you find that the patient is already making respiratory efforts. And it seems like the patient wants to breathe, but the patient is not moving their hands or any other part of their body. They are not moving their feet. And you're like, but what's going on? Why is my patient breathing? It's because of this. So the diaphragm is resistant to muscle relaxant. And then in terms of recovery, it recovers first. All of these are survival advantages. So the diaphragm has to be resistant because that's the main muscle that helps you to breathe. Then the adductor pollicis recovers later. This is also good for us in terms of anesthesia, because once you are able to stimulate the adductor pollicis, it tells you that the diaphragm is now already less blocked. So the patient, ideally, by the time you're getting reversal, by the time you're getting stimulation of the adductor pollicis, your patient ideally should already be breathing, unless the only caveat is if you've got a lot of opioids on board, then your patient may not be breathing. And not because the diaphragm is affected necessarily, but because you have blocked the respiratory stimulation centrally in the brain due to the effect of opioids, or you might have muscle rigidity from the use of opioids, muscle rigidity mainly in the chest wall rigidity, rather, due to the use of opioids, in particular remifentanil. So peripheral muscles, why do we use them? It's because They are amenable to stimulation. The nerves are superficial. They have a low innervation ratio. So low innervation ratio means that I'm able to isolate that particular muscle movement to one particular nerve. And the perfect example is adductor pollicis. When we stimulate the ulnar nerve, we will get flexion of the adductor pollicis. So that we talk about, we refer to that as a low innervation ratio. The effects of muscle stimulation must be visible. So if it's not visible, then you're not sure whether what you're doing is actually effective or not. So the nerves that we can use to stimulate, and they do ask this in the exam, is the ulnar nerve, which is basically the gold standard. We can use the facial nerve as well, especially if you can't use the ulnar nerve, but it's less reliable. We can also use the posterior tibialis nerve and the peroneal nerve. So in this presentation, I'm going to show you when we stimulate the ulnar, the facial, and the posterior tibialis. Peroneal, no, I don't have slides on that, but it's another nerve that you can also stimulate. So nerve stimulators are used for different reasons, not just for monitoring for muscle relaxation, but they can also be used for other things as well. Surgeons also use them, and for things like location of nerve, for local regional anesthesia, nerve mapping, detection of contractile muscle during surgery. But our main focus here is monitoring for muscle relaxation. Remember, when we also do blocks in patients, we can also use nerve stimulators to help us to improve or create a layer of safety so that we avoid injury to the nerves. So here are just pictures just to show you the nerve stimulators attached to the patient. This one, typical nerve stimulator for checking for neuromuscular blockade. This one is for checking for when you're using peripheral nerve, when you're doing peripheral nerve blocks. This is an example of where you would place the electrodes if you are going to monitor the facial nerve. How do they work? Okay, so what happens is that these nerve stimulators, they administer a certain current, and they need to have a certain voltage, a constant voltage. Why is that? Because you don't want changes. Because if there are changes in the voltage over that particular time, then it will affect how your interpretation of the stimulation. But what we are mainly able to dial up on the nerve stimulator is the current output. That's what we're able to dial out. And the values that we may aim for is 60 to 80 milliamps if you're using it for monitoring for neuromuscular blockade. If you are doing blocks, the current is much lower. It's about 0.2 to 0.5 milliamps. That's because when you're doing blocks, you're very close to the actual nerve and your needle has traversed the skin. Whereas with nerve stimulators for neuromuscular blockade, you are trying to stimulate the nerve through the skin. And because there's resistance, there's an element of resistance to pass a current through the skin, through the subcutaneous tissue and fat, you need a higher current. And that's the reason. So the nerve stimulators use what we call Ohm's law, which is voltage or potential difference is equal to the current multiplied by the resistance. And as I said, the current that we're aiming for is 60 to 80 milliamps. They do ask that in the exam. Then there are certain factors that are important that affect nerve stimulation. They are real base and connexy, polarity, electrodes, and resistance. I'll just touch a little bit on this. So real base is the minimum amount of current that is required to stimulate a nerve. That is why if you don't use the amount of current that's required, you won't be able to stimulate that particular nerve. Then connexy speaks to the time throughout that you are actually stimulating that nerve. So if you use a reliable current, but you don't expose that nerve to the amount of time that's required, then you're not going to be able to stimulate it properly. So you'll see that when I show you the different modalities of nerve stimulation, how this is important. Then polarity relates to where you're going to place the electrodes. And the electrodes are also important. They must be of a certain size and they must be a certain distance from each other. Then resistance is another important factor. So if you've got a patient with a lot of adiposity, you need to consider using a higher current because there's more resistance. It will be more difficult to stimulate the nerve. So if I have a patient who's got a lot of adiposity, I would use about 70 to 80 milliamps. I would go on the higher side. If you have a very thin patient, then you can easily go to something like 60, use the lower range. Then there's what we call a supramaximal stimulus, which is 2.5 to 3 times the maximal stimulus. Why do you need the supramaximal stimulus? Because if you go back to the neuromuscular junction, the electrical impulse is what then causes the acetylcholine vesicles to be mobilized. You need a supramaximal stimulus because you have paralyzed the patient. So you need a high amount of electrical current per se in order to mobilize acetylcholine, so that you can be able to see how the level of neuromuscular blockade that this patient has. So as I said, 60 to 80 milliamps is what you're going to use. The time is 0.2 to 0.3, and the skin resistance is about 0 to 25 kilo ohms. You don't have to know about the skin resistance, but the current and the time periods, you do need to know about that. So placement of the actual electrodes themselves. So we're interested in the ulnar nerve, as I said. So black tends to be the negative electrode. It might be different in different places, but different monitors might be different. But what you need to know is the negative is distal and the positive is the one that is proximal. The distance between them is about 4 centimeters, and this negative electrode is being placed just a little bit above the wrist, about 1 or 2 centimeters above the wrist. And they do ask this in the exams. So you're getting movement in the adductor pollicis. Sometimes what they do, the examiners, they try and trick you into saying you're going to put the electrodes on this side of the thumb. If you put them on the side of the thumb, in fact, you are stimulating the median nerve, not the ulnar nerve. So just don't get caught out on that. When it comes to the facial nerve, the difference now is that instead of the way it was appearing in the ulnar, you just switch the electrodes around. So the negative one is at the top, and then the positive one is the one that is distal. And here, when you stimulate the facial nerve, you are looking to get stimulation of, contraction of the orbicularis oculi. So when you put your hand over the patient's eyelid, you're expecting to feel that contraction. You can also put the electrodes over. Here, you're monitoring the posterior tibial nerve. So you're going to put them posterior to the medial malleolus. Again, just like with the ulnar nerve, negative is the distal one, and then the positive one is proximal. And then what you're going to get, the toe, the big toe moving like this. This is the flexor hallucis longus muscle contraction. So how do you measure the response? The response can be measured subjectively or objectively. So subjectively is by tactile or visual. So tactile means you are feeling it, and then visual is what you see. The best is an objective measure, because we all can feel different things, but the objective measure is what the machine will tell you the value is this, and that is the most accurate. But however, there are monitors that cannot give you an objective measure, and then you have to rely on the subjective way of monitoring. And I will show you the differences. So we're going to start with the subjective measure. So the subjective measure, as I said, again, electrodes distal, distal negative, positive proximal. You put your fingers all over the patient's thumb and you want to feel that thumb moving. Okay. So here's the actual live example of assessing for this. So this was a patient who was undergoing anesthesia, and then I was using the subjective form. So you see, okay. So I was feeling for the movement there. Okay. Then for the facial nerve, you're going to put your hand over the eyelid. Remember, it's the orbicularis oculi muscle contracting. You will feel the actual contraction of the muscle. I don't think I've got a video on this one. Then for the tibial nerve, posterior tibial nerve, you are going to see the movement there. And I think I do have a video for that. Okay, so we've got this patient. This patient was undergoing eye surgery, and then we wanted to assess the level of neuromuscular blockade. This type of device could not give us an objective measure, so it only gives us a subjective measure. There we are. So we got 4 twitches, so we have a train of 4 count of 4. Okay, we'll talk about that when we go through the presentation. So then there's an objective measure where you actually get a value from the machine. The types of nerve stimulators that are available, these are just the main types. The ones I've put in bold: acceleromyography and kinemyography. I think in our institution, we had the kinemyography. So it's similar principle, same thing, just that the only difference, acceleromyography, it's based on one of Newton's laws, but they will not ask you this for your level of exams. But the principle is the same. So Newton's second law, force equals to ma, it uses an accelerometer with a piezoelectric crystal, and based upon that, it is able to tell you the level of the muscle relaxation. Kinemyography, which is what I'm going to show you in the videos, is what we mainly had in our institution. Same thing, electrode negative is distal, positive is proximal. And then you have this device that you attach here to the thumb and the index finger. So it has what we call a mechanosensor. So it uses the machine is able to interpret this movement in the thumb and is able to tell you the level of muscle relaxation. Okay. So here's an example for kinemyography. Some of you in your institution might have this. Some of people don't, but if you don't, you just look and appreciate. So you have to press and activate the nerve stimulator and then look at what's going to happen to the patient's thumb. There we are. Then it gives you a value, 41%. I'm going to explain to you what that means. Okay. Mechanomyography, don't worry about that. It's just another way of assessing, and electromyography is just another way. I won't go into much detail with that. And phonomyography, it's another way of assessing for level of neuromuscular blockade. So the levels of block, you can have what we call an intense block, a deep block, surgical block, and then recovery. So most of our time when we do most surgeries, we want our patients to be to be at a surgical block or deep block. Intense block may be required for long procedures where they are very fine surgery. Maybe it's neurosurgery, which is microscopic surgery where the surgeon cannot afford for the patient to move. Otherwise, the whole operation will be compromised. In that case, you'd want an intense block. But most of the time, we prefer to have a surgical or deep block. Then the modes of stimulation on the nerve stimulator are single twitch, train of 4 count, double burst stimulation, tetanic, and post-tetanic count. The one that is mostly used is the train of 4 ratio. Okay, so that's what you'll find on most modern nerve stimulators. I will explain to you why would use the other modalities. But the one you need to know very well is the train of 4 ratio. That tends to pop up a lot in the exams. So single twitch, it doesn't have a lot of uses. So that's why people don't use it generally. It's only applicable at the time of induction. You can't use it at any other time. So why would we use single twitch? Single twitch is used to assess for adequacy of muscle relaxation at the time of intubation. So you're mainly using it as a baseline. You can't use it to assess for depth of muscle relaxation, intra-op. You can't use it to assess for recovery. It's a single supramaximal stimulus. It has a frequency of 1 hertz. It cannot differentiate between depolarizing and non-depolarizing. Why? Because it's a single twitch. And it requires a baseline value, because for you to assess whether the patient is ready to be intubated, you have to look at the amplitude of the twitch. So that's what you're relying on. So how does it work? You get one single twitch, and then after 10 seconds, you get another, and then after one, you get another. So what helps you to determine when the patient can be intubated is the twitch height. So you want a baseline, and for you to say, oh, I can intubate this patient, you want it to be a quarter. This twitch should be a quarter of what the original one was. And you can say a quarter or less than that, then you can say, oh, my patient is ready, is well relaxed, I can intubate now. This is an example of a single twitch. So you'll get just one twitch. So on this monitor, TW is a single twitch, TOF is train of 4, TET is tetanic, DBS is double burst suppression, and PTC is post-tetanic count. So we expect the operator to press TW. Okay, so you're going to press that, and you're going to expect one twitch only. There we are. So there was only one twitch. So as to whether the patient is ready to be reversed or not, we don't know. We really don't know, because it's just a single twitch. So with a single twitch, you must first have a baseline, and then you use that baseline to tell you whether you can intubate the patient or not. Then there's train of 4 ratio. This is the gold standard. You can only get a ratio when you have 4 twitches, and the twitches are at 2 hertz. That's the time, the interval between them. And the cycles, number of cycles per second. The ratio is the 4th twitch divided by the 1st twitch. You will get a fade if you use a non-depolarizing muscle relaxant. This signifies muscle fatigue. So you get 1, 2, 3, 4 twitches. This is your train of 4 ratio. So the train of 4 ratio, as we said, it is the ratio of the 4th twitch, T4, divided by the 1st twitch. So this is about 50% of this one. So the train of 4 ratio is 50%. So the machine would display 50%. So for surgical blockade, you want the ratio to be 25% and below. To intubate the patient, also less than 25%. To reverse the patient, you want it to be 90% and above. Previously, they used to say 75%, but recent literature says that at 75% is still not reliable. You may still have a risk of recurarization. So 90% is what we aim for to reverse the patient and also to extubate. So here's a video to show you. Oh no, this is not a video, it's just a picture. It's 94%, which tells you that the ratio of the 4th twitch to the 1st twitch is 94%. So in other words, this patient is reversible, and once you've reversed, you can extubate this patient. Obviously, bearing in mind other factors as well, that you've done every other thing, patient is stable, the surgery is over, and it's in a controlled environment, and you're ready to extubate the patient, and you've gone through your checklist. So in terms of the twitches, when we use a non-depolarizing muscle relaxant, we get what we call a fade. So you get twitch, 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 and then you get this thing called a fade. And also when the patient recovers, this is what you get. With succinylcholine, it's different. What you get, you just get an, in fact, go to D. For succinylcholine, this is a different, I'll come back to this one, which is succinylcholine. Succinylcholine, you don't actually get a fade. You just get 1, 2, 3, 4 twitches, 1, 2, 3, 4 twitches. And as the patient begins to be relaxed, you get a loss in twitch height. Okay, so the amplitude of the twitches is lower, but they are all at the same level. This is the pattern that you expect to get when you've given succinylcholine. But what about D? D occurs when you've given too much muscle relaxant, too much succinylcholine, rather. You get what we call a phase 2 block, and you get a fade, which is similar to when you give non-depolarizing muscle relaxants. Okay. So this is your train of 4 ratio again. So it's the ratio of the fourth to the first twitch. What this picture is just trying to show you is a control. So when your patient is asleep, so you never stimulate, you never activate the nerve stimulator and the patient is awake. It's very painful. So let's say you've given propofol, the patient is asleep now, you start your nerve stimulator, you get your control. So you're going to get this. The twitch height is 100%. If you give a depolarizing muscle relaxant like succinylcholine, you will get 2 twitches. And when the patient is relaxed, the twitch height will be the same, but the amplitude of the overall amplitude will be less, but the 2 twitches, the height will be the same, but the amplitude compared to the control is less. I'm going to leave this one and move to this one. So initially, no muscle relaxant on board, no muscle relaxant, we've just given propofol. Now we decide to give rocuronium, okay? Still, we're getting as if it's almost normal, but after some time when the rocuronium begins to kick in, we start getting what we call this fade now. And then initially we have a train of 4 ratio of 0.81, 0.66, 0.44, and then once it's less than 0.25, you can intubate your patient. So this is what you will get on your nerve stimulator if you were using a nerve stimulator in an automatic mode as you are about to intubate. I've already talked about this. So at 25%, depending on how far your surgery, you might consider topping up, but 25% and below, patient you can go through with the surgery. As I said previously, they used to talk about 75% is reversible. The current literature now says 90% is reversible. And after you've given the reversal, then when it's more than 90%, you can extubate. No fade, as I said, seen with choline, only if you've got a phase 2 block. And you must never do this in patients who are awake. Okay. Right, I think we've talked about this already. I'm not going to go into this just to not waste any more time. So let's move on to double burst stimulation. So we've talked about single twitch. We said single twitch, you can only use it at the beginning. You need a baseline. It helps you to determine when you can intubate a patient. Train of 4 ratio, you can use it throughout the whole procedure. So you can use it to determine when you should intubate, when you should top up the muscle relaxant, when you should reverse a patient, and it helps you to decide when it's safe to extubate the patient. Then there's this one called double burst stimulation. This one, you can't use it at the beginning. It's mainly to assess if you still have residual muscle relaxant on board. You must never do it in a patient who's awake. It's extremely painful. What you typically get, you get 2-minute tetanic bursts, which are at 50 hertz, which means it's quite fast as compared to single twitch, which is just 1 hertz, and the train of 4 ratio, which is 2 hertz. So this one is stimulating very quickly, and the impulses are 2 to 3 impulses. It might be 3 to 3 or 3 to 2. It can differentiate between depolarizing and non-depolarizing because you will get a fade. It's used to assess residual muscle blockade, but it's subjectively. So this is what you get. You get the burst. As it said, double burst suppression, stimulus, sorry. So it's 1, 2, 3, 2. Okay. Or it can be 3, 3, 3. Some of them can do that. So here's a video just to show you what double burst suppression looks like. And you'll see why I say you should never do it in a patient who's awake. So there I am, activating the nerve stimulator. There you go. Look. So the stimulation is quite violent, I must say. And for this to happen, you actually have to you're stimulating the mobilization of the acetylcholine in the patient's nerve fiber. So it can be quite painful. Then there's post-tetanic count. So we talked about single twitch, train of four ratio, double burst stimulation, and then there's post-tetanic count. It's used in deep neuromuscular blockade. So let's say, for example, you've given a lot of muscle relaxant and you actually don't have any twitches anymore. So you want to know how long is it going to take for you to get the first twitch? This helps you to decide whether if you really want an intense block, to give more muscle relaxant, or how long you're going to wait till you start getting twitches, and that will help you to decide how soon you can reverse the patient. Again, it's 50 hertz for 5 seconds, so it's quite quick. You must never do it in a patient who's awake. It's extremely painful. And as I said, the aim of these rapid impulses and stimulation is to mobilize the acetylcholine presynaptically. Why do you want to do that? Because these patients have an intense block. So you want to mobilize as much acetylcholine is available so that you can be able to determine how long it's going to take for you to get a first twitch and how deep, really deep these patients are in terms of muscle relaxation. So here are the twitches, and with this one as well, you can also get a fade. Here's an example of tetanic stimulation. So it can be very painful. Okay, so there I am again activating the nerve stimulator. And then there we go. 50 hertz. You get tetanus. Yeah. Move on to the next one. Then post-tetanic count, similar to the same thing. You're getting mobilization of acetylcholine, and then you get these single twitches, about 20 of them. Again, this one, you must never do it when the patient is awake. It's used when you've got an intense block to assess when you're going to get the first twitch on your train of 4 count. Okay, we activate the nerve stimulator. There we go. So we get tetanic count, tetany, and then post-tetanic count. There we are. Again, the twitches. There we are. So then it gives you a value to say how many twitches we had. So here we had 10 after we mobilized acetylcholine. Okay, so then there are tables. Actually, it's beyond the scope of this presentation. There are tables like, for example, if you're using a drug like rocuronium, they will tell you that when you use the post-tetanic count and the patient has an intense block and you get the post-tetanic count of so much, you must then give so much of the reversal agent, because the reversal agent for sugammadex, so for rocuronium is sugammadex, and at high doses, you can get complete reversal after 3 to 5 minutes after giving it, and the patient can actually become extubatable at that after that 5 minutes from a deep or an intense block to completely extubatable. So this nerve stimulating modality can help you, especially if you're using drugs like rocuronium and you've got the tables that can assist you in dosages. Okay, so this is a very nice diagram. I like it because it summarizes basically what I was talking about. So if you've got, you're starting off, okay, so you're starting off, you've induced your patient with propofol, and then you give your whatever other drugs you've given. Patient is drifting off to sleep. Then you give your muscle relaxant. And as you give your muscle relaxant, you start getting fade. You still have 4 twitches, but now the patient is much more relaxed. And then you decide, let's say, for example, you decide to give more muscle relaxant. And when you do that, now you have an intense block. Now you don't even have a twitch anymore. And because you don't have a twitch anymore, you decide to use post-tetanic count, because that's when it's indicated. Then your post-tetanic count stimulation during a deep block gives you this number of twitches. Then as time goes on, as the muscle relaxant begins to wear off, now you start getting 1 twitch on the train of 4 count. You get a second twitch. We say that a train of 4 count of 2. You get a third twitch, train of 4 count of 3. You get 4 twitches, a train of 4 count of 4. Once you have a train of 4 count of 4, then you can then calculate your train of 4 ratio. So remember, the train of 4 ratio is the 4th twitch to the 1st twitch. Without 4 twitches, you have a train of 4 ratio of 0. You can't calculate it. Okay. Only when you have 4 twitches is when you can be able to say you have a train of 4. You can be able to calculate the train of 4 ratio. This is another very nice quick summary, because they like to ask this in the exam. The indications for the different modalities. So single twitch, you get 1 Hertz, and it's mainly used for tracheal intubation. During the time of induction is where you're going to use single twitch. Train of 4, it can be used during tracheal intubation. It can be used to assess for moderate block and to decide for reversal. Then they say you can use it in recovery. This is a theoretical aspect, but in real life, you should not be using an nerve stimulator in recovery, because it's very, in the recovery room, it's very painful. Then post-tetanic count is used for an intense or deep blockade. Here you want to find out how long is it going to take for you to start getting twitches on the train of 4, so that count, so that you can be able to decide whether you're going to top up or when you're going to how you're going to reverse the patient. Then double burst stimulation is when you use it to assess for residual muscle relaxant. And now you're thinking, do I still have muscle relaxant on board? And you want to reverse the patient. I must say, I've never really used double burst stimulation in my day-to-day practice. It's mainly, for me, it's mainly academic. I have used single twitch, yes. I've used post-tetanic count, yes, because it makes clinical sense. And train of 4, yes, those ones I have used because they make a lot of clinical sense. This is also a nice summary of the differences, and they like to ask this in the exam, both for the diploma and the part 1s. What are the different modes and the clinical use, which I have been mentioning to you throughout the entire presentation. Okay, so this doesn't apply anymore. In current literature, this has been updated. So we are having higher targets now for extubation, for example. So we're aiming for more than 90%, more than 90% recovery. And definitely, we are no longer saying just 10%. We want it to be even less than 5%, for you to be able to extubate. So about 90% recovery or 10% suppression, when you are more than 10%, for you to give the reversal. But when it comes to extubation, you definitely want it to be much higher than that, because that's what the new literature is saying. The reason why is because they now started noticing that patients still had pharyngeal muscle weakness at the time of extubation, which puts them at a risk of aspiration. Though they may be breathing very well with good tidal volumes, but the pharyngeal muscles could still be weak. And then if you take out that tube, there's a high risk of the patient aspirating, because their airway reflexes are not yet fully recovered and intact. Reversal agents, as I said, neostigmine and glycopyrrolate or atropine is mainly what you probably are using in institutions. Sugammadex is also is used for reversal, in particular for rocuronium. It can be used for other aminosteroids like pancuronium and vecuronium, but when it was made, it was mainly targeted at rocuronium. The dose is 4 milligrams per kg for a patient. If you are reversing, obviously, when you've got a train of 4 of more than 90%. But if it's an emergency, you need to reverse the patient's stat, you can use 16 milligrams per kg to reverse the patient as soon as possible so that you can you reverse all the muscle relaxant, and maybe you want the patient to breathe on their own. However, you need to know that Bridion or Sugammadex, Bridion is a trade name, is expensive. I think there is a generic that's coming out that has just come out recently, but generally it's quite expensive. So if you look, if we have in physiology, the typical weight of a male subject, according to the physiology textbooks, is 70 kgs. So if you needed 4 milligrams per kg, that is 70 times 4, which is 280, which means, in fact, you may need more than 2 vials, because the Bridion is about 200 milligrams that you're getting from 1 vial. So if you need 280, you will need 2 vials. And 1 vial, and I'm speaking according to South African standards, I think 1 vial costs about more than 1,000 rands. I think more than 1,000, more than 1,500, or even more than that. So it becomes really expensive for you to use this, especially in the government sector. In the private sector, the patient's medical aid will be charged. So you must always think to yourself, should I use Bridion or not? You need to balance issues. So if you need to get the patient off the table and they need to get the patient out as soon as possible, then probably going with Sugammadex, if you've given rocuronium, might be your best bet, because the advantage of Sugammadex is that, unlike neostigmine is an acetylcholinesterase inhibitor. Sugammadex, what it actually does, it chelates it, or it encapsulates the rocuronium, and that's how it clears it. But it does require for the patient to have working kidneys, because the Sugammadex rocuronium complex is excreted by the kidney. So if a patient has got acute kidney injury, a chronic kidney injury, chronic kidney disease, rather, I must say, they probably are not a good candidate for Sugammadex, because they won't be able to excrete the Sugammadex rocuronium complex. So neostigmine might be there, with glycopyrrolate might be more attractive in those patients. Yeah. So even using Sugammadex does not mean you might not get recurarization. Just know that you might still get it, but the risks of getting recurarization is much lower than if you were to give neostigmine with glycopyrrolate when the patient is not ready for reversal. So that's what makes Sugammadex superior. Another thing also to note is that Sugammadex can cause an anaphylactic reaction. Initially, when it was rolled out in America, it did cause anaphylactic reactions, and they had to withdraw it. I think that was in 2005. And then they had to reintroduce it later on. So that's just an important thing to note. Then there's another reversal agent called Calabidion. I think that one is mainly for reversing benzyl isoquinones, but I have never used it and I've never seen it. It's mainly something that from what I've seen, is mainly theoretical. So Sugammadex, they will ask you this in the exam. So if you've got an intense block, the dose you want to use for Sugammadex is 16 milligrams per kg. For a deep block, 4 milligrams per kg. For a moderate block, 2 milligrams per kg. But I must say, for me, if a patient was not in an intense block, they just had a moderate to deep block, I tended to use 4 milligrams per kg. I found using 2 milligrams per kg was just, I found it to be quite too low. I didn't get as quick a response as I desired, especially if you're going to use Sugamadex. If you've decided to use it, I would say go big or go home. Don't go for 16 because then you're just going to be wasteful. But I would say if you're deciding to use it, you've made a decision to use it, I would just go for 4. Then you are guaranteed that, yeah, you've reversed the patient. Yeah. Residual blockade, I think we've talked about that. It impairs carotid body, has chemosensitivity to hypoxia, partial inspiratory airway collapse may occur, regurgitation, aspiration, which we do not want, can cause blurred vision, and it's uncomfortable for the patient. Patient will keep saying they can't breathe properly, and they keep flapping around. Typically, they keep lifting up their hands up and down. That's a sign that the patient might have a residual muscle blockade. Okay, so in summary, I think I've spoken a lot. All patients who have a non-depolarizing muscle relaxant should have a nerve stimulator. You should use a nerve stimulator with them. It's not always necessary to use a nerve stimulator when you're using drugs like succinylcholine, because we understand the mechanisms of succinylcholine, and it's broken down by pseudocholinesterase or beta-cholinesterase, and we don't reverse succinylcholine. However, you could consider using a nerve stimulator if you suspect the patient has got succinylcholine apnea, because then you are going to see that maybe the twitch height might be diminished, or if they've gotten too much muscle relaxant on board, you may see a fade pattern. So more than 90%, here when I made this presentation, I said gold standard for extubation. The new literature, as I said, more than 90% is for extubation, but we want to reverse at 90 and above, and then we extubate above that. Okay. So clinical signs alone are not sufficient for extubation. So normally people might have been teaching you anesthesia. When you're still starting, they'll say, if the patient is kicking, or if the patient is moving the legs, or the patient is lifting the head, you can extubate. Yes, you can do that. You can, we've done it before, but just know that it's not reliable. Just because the patient is moving the legs or kicking, because my juniors will tell, doc, the patient is kicking now, it's okay to take the tube out. That does not necessarily guarantee that the airway reflexes are intact and are completely recovered from the muscle relaxant. So you must put more clinical signs together, including your nerve stimulator. So you look at your hand grip, your head lift, tongue protrusion, cough reflex, together with your nerve stimulator, having more than 90%, having reversed the patient. And then you're sure there are no other contraindications to extubation. There's also the concept of a train of 4 count. I didn't hammer that a lot, but the train of 4 count is 2 twitches. So some textbooks say if you've got more than 2 twitches when you're using the train of 4 count, you may reverse the patient. I have done that in the past, but I still say you have to be cautious, else the gold standard remains the train of 4 ratio. So Gamadex may be used to achieve full reversal regardless of train of 4 ratio with the dose of 16 milligrams per kg. Remember, there are charts that can help you in the dosing of Gamadex using your post-tetanic count as well. If you have them in your institution, I recommend that you look at them. They will assist you. So these are references. I mainly used Barash, clinical anesthesia, and Miller's anesthesia, and an article by Naguib in 2019 to compile this presentation. And I also just want to say I did use YouTube, that YouTube video, so I have to declare that because there's copyright issues that I showed you. I did modify the YouTube video, cut out some stuff so that I only show you the relevant portions. It's quite a lot I had to go through. It took me time to prepare this presentation. And it's something that I did spend a lot of time reading up, because in my early days of anesthesia, I couldn't really understand this. And no one in the department could really explain to me and give me the adequate explanation that I really wanted in order to understand this. There are still things I also want to learn, but I must say I spent quite a lot of time reading this, and I got more clarity on this subject, and that's why I wanted to share with you guys. I don't know if anyone has got any question. It's been a long presentation. I hope I didn't speak you to sleep. Hope you didn't sleep with your phones on your side. Does anyone have a question you want to ask? Is it clear or I confused you? Okay, so if you have any questions, you're welcome to reach out. You can also post on the WhatsApp group, and then we'll try and clarify them.